Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. Continuing on with the top 200 drugs, we've got number 136, and that is Cinacalcet. Brand name of this medication is Sensipar. This is what's classified as a calcimimetic medication. Ultimately, what we're trying to do with this medication is treat primary hyperparathyroidism, secondary hyperparathyroidism, I would say more typically secondary hyperparathyroidism, but elevations in calcium can occur from this disease state, particularly in patients with CKD. And this medication can treat those higher calcium levels. And mechanistically, it does this by increasing sensitivity of calcium receptors. And ultimately, this is going to cause that serum calcium to go down as that calcium is uptaken into the cells. Okay, so that's ultimately going to reduce calcium and going to reduce PTH there as well. Some warnings, some things to pay attention to. There have been arrhythmias associated basically with the drug working too well if we're not paying attention to lab work. So if that calcium level drops too far, we can run into a situation of causing life-threatening arrhythmias as well as life-threatening hypocalcemia associated with that. So adverse effect profile, as you could imagine, just alluded to that. We can drop that calcium too far, cause low calcium levels. Drop in blood pressure can happen with this medication as well. And GI bleed has been associated with this medication as well. So think of it along the lines of, NSAIDs, for example. Some considerations, some things to look out for. Typically, that tablet is going to be taken with food or shortly after a meal. That makes sense, I think, with some of the GI concerns that we have in the adverse effect profile. Closely going to monitor serum calcium, PTH levels. Again, we want to bring that calcium level down typically when we're using this medication. That's one of the goals typically. But we don't want to bring it down too far. For a reference standpoint, typical total calcium levels, again, this can vary from lab to lab, but most commonly 8.6 to 10.2 milligrams per deciliter. Drug-drug interactions, finishing up with this, Cinacalcet does inhibit CYP2D6. A medication like tramadol can have its concentrations increased. Fluoxetine's another example. Paroxetine, those are both SSRIs. Amitriptyline's another good example of a medication that's broken down or deactivated, if you will, by CYP2D6. So again, those concentrations, the activity of that medication can go up when we add a medication like Cinacalcet. On the flip side, we've got a drug like tamoxifen, which is a prodrug, actually activated by CYP2D6. So this can ultimately reduce the effectiveness of tamoxifen, a medication for certain types of breast cancer. QTc prolongation has been associated with this medication as well. That's particularly true if we drop that calcium level too far. Next medication, we've got Solifenacin. Brand name of this med is Vesicare. This is number 137 on our list. This is an antimuscarinic, sometimes called an anticholinergic agent. It is meant to primarily target bladder tissue, but as with many medications, sometimes we don't get that selectivity that we exactly want. So from an adverse effect standpoint, you can anticipate that we're going to have some anticholinergic adverse effects. Again, dose dependent, higher the dose, the more likely we are to incur some of those anticholinergic adverse effects. And some of those adverse effects, dry eyes, dry mouth, urinary retention, constipation, CNS changes like confusion can happen, fall risk, hyperthermia can happen as well. Again, pretty rare on probably the hyperthermia, but if you've got patients living in warmer areas, for example, maybe very hot in the summer, for example, that risk may go up for hyperthermia in patients who are in warmer areas. Obviously, maybe also working in those areas, living in those areas, are exposed to excessive heat. All right, so using this medication for bladder purposes, it is a competitive antagonist at the muscarinic receptor. Primary use is going to be overactive bladder. And when I think about that mechanism and relating it to drug-drug interactions, first and foremost, I'm going to think of anticholinergic burden. This is a big thing, particularly in geriatric patients, where we, get polypharmacy patients and maybe they're taking multiple medications that have anticholinergic activity, and we can kind of pile on that anticholinergic burden with a medication like solifenacin. So that's kind of the first drug interaction I think of as some of those additive adverse effects, the dry eyes, dry mouth, constipation. Another potential drug-drug interaction, we've got potassium chloride. So you'll see this flag quite often. I will say I do see these medications still used together occasionally. Some drug interaction checkers will say it's contraindicated, others may not. What the issue is here is in slowing down that GI tract with anticholinergic activity, which this medication has. It can actually increase the risk of that potassium tablet not moving through and getting stuck in the esophagus or in the GI tract. And that can stick and cause some irritation and a potential even ulceration if it's bad enough. So solid oral dosage forms of potassium, there is some potential risk there that I think you should pay attention to. Other drug-drug interactions, ketoconazole, that can potentially increase concentrations of solifenacin. There is some potential QT prolongation risk. Not one of the medications that I think of as really, really high risk compared to, let's say, like amiodarone. But we do have some potential QT prolonging risk there. We just got this recent testimonial on our BCPS study materials that I wanted you guys to hear. This was from Monica. I'm elated to announce that I got certified in BCPS. This has been on my list for a year, and I'm happy to accomplish this goal. This post would be incomplete if I didn't mention Eric Christensen and MedEd 101. His material played a huge role in my preparation. We work on our study materials every year for NAPLEX, BCPS, ambulatory care, BCMTMS, geriatric exam. Go check out meded101.com/store. We can definitely help you prepare and pass your exam just like Monica. So again, go check out meded101.com/store. Your support goes to directly support this podcast, and I greatly appreciate it. Next medication is haloperidol. Brand name is Haldol. This is a first-generation antipsychotic. It ultimately blocks dopamine 2 receptors in the central nervous system, and that's how we manage schizophrenia, for example, where we have an excessive amount of dopamine in the brain that causes some of those symptoms associated with schizophrenia, like hallucinations and delusions, for example. Haldol is very, very old medication, been around for quite some time, so it's got a ton of unique indications as well. I'm not going to go through all of those, but it can be utilized in bipolar disorder. I probably see it most often used for various states of delirium and agitative states. In my geriatric patient population, I definitely see it used in hospice for end-of-life agitation and anxiety. Nausea it can be used for as well. So again, many kind of unique indications with haloperidol. We do have multiple dosage formulations. We can give it by oral route, IM route, for example. There is a boxed warning. Increased risk of death in elderly patients with dementia-related psychosis. That's always a good one to remember, one that can definitely come up on pharmacology exams or board exams. From an adverse effect profile, the list is definitely long. Biggest one that I would encourage you to remember is extrapyramidal symptoms. So any kind of unique movement symptoms that you see in a patient that can be caused by antipsychotics and haloperidol more specifically here. Low blood pressure can happen. There is some anticholinergic activity with this medication as well that can lead to some constipation and dry mouth, for example. QT prolongation is a risk as well with this medication. But again, I would say probably the most tested one, the most common one that we pay attention to is the unique extrapyramidal symptoms that an older antipsychotic like haloperidol can cause. Tardive dyskinesia is also a possibility with this medication. We utilize assessments like AIMS or potentially discus. Also can cause neuroleptic malignant syndrome. Again, pretty rare syndrome, but it can cause like fever and muscle rigidity. Again, higher doses, younger patients will have a higher risk of NMS than, say, an older hospice patient on a very low dose. Okay, so the dosing definitely is an important thing to think about there. From a drug-drug interactions standpoint, there are some CYP2D6 interactions to pay attention to. Metoclopramide is a GI medication that can be used for nausea and gastroparesis. This has additive dopamine blocking activity, so it could increase the risk for those extrapyramidal symptoms, those movement type symptoms, as well as neuroleptic malignant syndrome. In a patient we're treating Parkinson's, most common medication there is Sinemet. Haloperidol can directly oppose beneficial effects from Sinemet, so it can make Parkinson's symptoms worse. So definitely a good one to remember there. Sinemet, we're trying to give dopamine. Haloperidol, we're trying to block dopamine. So we're kind of opposing each other there with using those two medications together. Lastly, I'll mention QTC prolongation, antiarrhythmics, other antipsychotics. These are all medications and medication classes that can increase that QT prolongation risk. Number 139 is hydrocortisone. This is a corticosteroid. Mechanistically, it's a naturally occurring adrenal corticosteroid. Has anti-inflammatory type activity, vasoconstrictive type activity, as well as some antipyretic or anti-itching type activity as well. Now, I am going to focus more so on the topical agent here. That's what you're going to see most commonly used. It's available over the counter, and that's going to be typically given for dermatitis, localized skin reactions, and it helps with the itching and it helps with the redness. There's no doubt about that. From an adverse effect profile, I typically don't worry about systemic adverse effects when we're using topical hydrocortisone. With that said, if you get a crazy situation where the patient is trying to apply it all over their body and they're maybe getting some systemic absorption, that is a potential risk. Again, pretty low risk in patients that are just using it for small areas. But those systemic risks, if there is exposure or if we're using oral or injectable or systemic hydrocortisone, those systemic adverse effects include elevations in blood pressure, fluid retention, osteoporosis risk, hyperglycemia, weight gain, and increased risk of infection. So, lots of potential negative consequences there if we do have significant systemic absorption. Now, from a topical standpoint, probably the biggest thing that I think of, particularly in geriatric patients, it can cause some skin thinning, and if there is an infection there on a small area of skin, for example, it can impair wound healing and maybe increase the risk for infection. So those are some things to look out for in recognizing whether it's a skin reaction or whether it's a skin infection. that's going to be an important thing that, a clinician should assess there. From a drug-drug interaction standpoint with topical agents, I'm really not too concerned here as far as drug-drug interactions go. From a systemic standpoint, obviously, hyperglycemia. So if you got a patient who is taking diabetes medications, it can kind of counteract that. Same thing with osteoporosis. It could make that worse, kind of counteract anything we're trying to do with medications there. But again, from a topical standpoint, not too much that I'm worried about as far as drug-drug interactions. Last medication, number 140, we've got an insulin product. I wanted to cover NPH here. So this is an intermediate acting insulin. Ultimately, mechanistically, all insulins stimulate glucose uptake through inhibition of hepatic glucose production and glucose uptake by skeletal muscle and fat as well. So indications, type 1, type 2 diabetes. One of the things that you've got to recognize with intermediate acting insulin, it's typically going to have to be dosed twice daily, maybe even sometimes 3 times a day. I've seen in some cases. So that gets to be a challenge where we're having to give the patient multiple injections of this medication. And this is why this intermediate acting insulin has fallen out of favor and given way to some of the long-acting insulins that can be dosed once a day, for example. So insulin glargine is an example there. Probably the only benefit, the only thing NPH has over the top of some of the longer-acting injectable insulins is cost. Patients may be able to get this more cheaply, and I have had cases in my career where I've had a patient utilize long-acting insulin as long as they could, and then when they couldn't afford it or insurance wouldn't cover it or they stopped getting discounts, then they would actually switch over to NPH. So again, very difficult situations. Hopefully your patient never has to go through that. Again, have seen situations where that has occurred or patients have utilized that to try to save money. But when we give more frequent doses of insulin, you get a little bit more kind of peaking and troughing with insulin NPH. So managing hypoglycemia versus hyperglycemia, that can get a little bit more tricky, in my opinion, with NPH because we're dealing with multiple peaks and troughs. Then you throw on short-acting insulin for meal times. That can add in a whole other variable as well. And so it can get really, really complicated really fast when we're talking about taking multiple different insulins at multiple different times of the day. So again, NPH, probably aren't going to see it, too often in your career, at least hopefully not. It does make things a little bit more complicated. So make sure you understand kind of the peaking and the troughing of when that insulin goes up and when it comes down, and recognizing it with your patient, making sure they're monitoring those blood sugars closely. So biggest adverse effects of virtually any insulin is hypoglycemia, dropping that blood sugar too low, as well as weight gain. Those are probably the two biggest things to pay attention to. Can drop potassium levels some. Usually with chronic use, that's kind of stabilized and generally not too much of an issue. Injection site reactions, I should also mention that. We want to rotate those injection sites so we don't have issues with that. From a drug-drug interaction standpoint, I think about some of the meds that raise blood sugars, corticosteroids being probably number 1 on my list. Thiazide diuretics may be associated with that as well. Other diabetes medications. Anytime you add another diabetes medication, obviously we're trying to lower blood sugar in combination with insulin therapy that could drop it too far potentially. So again, when we start a new medication, new diabetes medication, it's a great time to watch those blood sugars a little bit more closely, making sure that we're not dipping too far there. Well, that's going to wrap up the podcast for today. Thank you so much for listening. Do me a huge favor. Go sign up at reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great study guide, great refresher, whether you're out in practice or you're studying as a student. Definitely a no-brainer to have, and simply an email will get you access to that. Also, go support the sponsor, meded101.com/store. I've got a growing list of resources there for pharmacists, nurses, pharmacy technicians, practicing clinicians, all sorts of good stuff. Any purchases there go directly to help support this podcast, so I greatly appreciate that. If you want to reach out to me, Eric Christensen, PharmD, BCPS, BCGP, you can connect with me on LinkedIn. You can track me down at mededucation101@gmail.com as well. Thank you so much for listening, and I hope you have a great rest of your day.